Why I, as a cardiologist, use alpha keto analog? That is what you would be wondering. But what you need to realize is when it comes to kidney disease, the heart is essential, especially when it comes to cardiorenal syndromes. The kidney cannot do without the heart, and the heart cannot do without the kidney. So keep a watch on both. So cardiac patients face severe metabolic stress, inflammation, and catabolism. They may be having pre-existing chronic kidney disease, or they develop acute kidney injury perioperatively. Protein restriction is essential in such patients, but also increases the risk of malnutrition. Balancing adequate protein nutrition along with renal protection is essential. And alpha keto analogs, I believe, help in bridging this gap. So what it allows is for lower protein intake, and it also maintains the nutritional status in patients, especially reducing the nitrogenous waste. So what are the nutritional challenges? Perioperatively, especially post cardiac surgeries, there's a lot of inflammation, surgical stress, protein breakdown, and muscle loss. You have preoperative fasting, delays in surgeries, glucose-free crystalloids, which are given, extended long critical surgeries. The duration of surgery becomes long. You have positive end pressures that cause a lot of damage to the lungs, sedation, and already the patient may be having other premorbid conditions, existing malnutrition, and various other issues. See, if the patient is already at a stage where the patient needs a cardiac intervention, that means the patient will be having something which is uncontrolled, either blood pressure, diabetes, or cholesterol, which is already causing systemic inflammation, and there is definite some amount of nutritional imbalance which is going on. All of this, along with volume overload for heart failure and gut edema, is also adding to the kitty. Malnutrition is linked to poor wound healing, infections, longer ICU stays, and higher mortality. Especially in cardiac surgery patients. See, the cardiac surgery patients already have heart failure, cardiac cachexia, sarcopenia, less functional and metabolic reserves, increased hemodilution, and endothelial dysfunction. And such patients, when they undergo critical long surgeries, they have worse functional recovery, higher rate of infections, increased rate of pneumonia, increased hospital stays, increased ICU stays, decreased discharge to home rate, and increased morbidity and mortality. So as you can see, when a patient has heart failure, you have multiple issues. Fluid overload causing congestion, tissue hypoperfusion, neurohormonal activations elevated, protein degradation, all of this causing anorexia, which in turn leads to malnutrition. Because of the low cardiac output states, patients are fatigued, depressed. They also have reduced appetite. I keep telling my patients that whenever you get a cold and cough, you lose your taste of your mouth. So if your heart is not doing well, obviously you will not be able to eat. So malnutrition is a big issue for cardiac patients. When it comes to all of this, there is an anabolic catabolic imbalance which is going on. All of this leads to low proteins in the blood. This entire thing leads to various degradation of protein pathways. So you have a triad of malnutrition, inflammation, and atherosclerosis, all leading to increased cytokines, increased oxidative stress, endothelial dysfunction, and calcification. And in turn, when there is cellular inflammation, it causes increased kidney dysfunction, cardiovascular disease, and various other comorbidities, making the patient more susceptible to infections, frail, and sarcopenia. You have major cardiovascular events and kidney events which increase, and mortality increases. So this triad is the MIA syndrome, the malnutrition, inflammation, atherosclerosis syndrome. When you have a patient with heart failure, no matter which heart failure it is, heart failure is of three types, where you have low range, mid range, and preserved ejection. So in low range is a no-brainer, right? When the heart pumping is less than 40%, you have to reduce the fluid intake. In mid-range ejection fraction from 40 to 49, and in preserved ejection fraction, people say that their heart pumping is normal, but yet they have NT-proBNP which is high. They'll be having increased fluid accumulation in the lungs and the legs. That's because fluid restriction is essential no matter what your heart pumping is, if you are having any form of heart failure. So it is heart failure with preserved ejection fraction or diastolic heart failure, where the heart relaxation is abnormal. All of these patients also tend to have a lot of CKD. They have cardiovascular issues, coronary artery disease, heart failure, arrhythmia, sudden cardiac death. So CKD itself is a subset to cause inflammation. And it's not only inflammation, you have multiple issues that are occurring at that point of time. On the heart, you're having oxidative stress, hypertension, CKD, myocardial disease, valve diseases, and fibrosis. When it comes to the kidney issues, you're having inflammation, calcification, uremic toxins, coagulation, hypertension, various other peptide issues. And at the vascular level, again, you're having coagulation, dyslipidemia, calcification, inflammation, peptide issues, and hypertension. So this is the triad of cardiorenal syndrome. Especially when a patient is having um, post-cardiac surgery, cardiopulmonary bypass surgery and low cardiac output, all of it causes renal hypoperfusion. So you have up to 7 days post surgery, up to 90 days post surgery, and more than 90 days post surgery. So the whole point is we already know that the patient is having a heart issue, and we have to prevent further acute kidney disease, right? So the adverse outcomes are an increase in death, increase in dialysis, and new heart failure. And post-operatively, you have multiple AKI issues, advanced age, low albumin levels. All these are risk factors that make sure that the patient will go further into CKD and heart failure. High ventricular pressures, which are there post-surgery, and heart failure at 3 months post-surgery. This is all a continuum. Now it's the protein dilemma. Should we increase the protein to help increase the nutrition, or should we reduce the protein to make sure that the amount of nitrogenous waste is less in the blood? And this is where alpha keto analogs fill the bucket. So alpha keto analogs are beautiful in the sense they are nitrogen-free analogs of essential amino acids. The key feature is that the carbon skeleton of these amino acids lack the nitrogen containing group. So once ingested, they undergo transamination in the body, and there is an acceptance of nitrogen from non-essential amino acids, converting them into essential amino acids. That means that it allows for protein synthesis with lower nitrogen intake. All of this results in less urea generation and reduced renal burden. Urea, we would tell such patients to hydrate better. But since these patients are of cardiac failure and they are more prone to having an increased blood urea nitrogen level, then this is something that we use very, very often. So what is the mechanism of action for these keto analogs? When these keto analogs are given along with the various vitamins which are there, these nitrogenous waste products are accepted and essential amino acids are formed. And in neurotransmitters, hormones, growth of muscles, various other cellular processes. And all these protein and amino acids are there, which are then also used for energy, glucose, fat, and other things. So what are these benefits in cardiac patients? They allow for protein restricted diets without malnutrition. You reduce the nitrogenous waste, help protecting the kidneys. You improve biochemical parameters like blood urea, nitrogen, and serum phosphate. You also help reduce the incidence or the severity of post-operative AKI. You support muscle maintenance and healing during recovery, and enable safe nutritional management in patients needing fluid and protein restrictions. Cardiac patients to be considered for alpha keto analog therapy. Post-cardiac surgery patients with a rise in urea and creatinine, all of these patients we do add alpha keto analog. If the patient is having a CKD and we are planning for an angiography, I tend to add, especially if the blood urea nitrogen is high and I cannot hydrate the patient much with fluids. If patients are at a higher risk of AKI, I do add alpha keto analog. and if such patients are on a protein restriction. So you can use either one tablet single strength or a double strength tablet for a 10 kg body weight. I basically add Saffrolog DS twice a day for my patients. One tablet twice a day, it really helps. You also have to look at the nutritional status, the electrolytes, especially calcium and phosphate, and various other renal parameters. So basically, we use alpha keto analog in post cardiac surgery patients, even in pre and post angiography patients, right? Balancing protein needs with kidney protection is critical. Alpha keto analogs help protein nutrition and reduce nitrogen load. And they are also a valuable adjunct in cardiac patients with CKD who are at a risk of developing post-operative renal dysfunction. Thank you.
Thank you so much, sir. This was a very comprehensive yet a crisp presentation. So we have received few of the questions from our doctors before the session itself, and I would like you to take that up. So the first question was, how do you balance the need of high protein intake during the post-surgical recovery and with the need to protect the kidney function in the high-risk patients?
So see, if you look at what the EGFR for the patients are, if they already have CKD stage 3, stage 4, and they have to undergo a cardiac surgery, then they are at a very high risk for post-surgical worsening of AKI. In such patients, you cannot even give a high protein diet. And that is where I give Saffrolog DS twice a day. That's basically because these alpha keto analogs give proteins, essential amino acids without the nitrogen. So the blood urea nitrogen in such patients don't increase. And they really help in supplementing, not totally, but you're giving essential amino acids to your patients. And what I really like is the way that Saffrolog is, it doesn't give the patients that fishy aftertaste which is there, which certain other brands do. So that is what I really liked about it, because the patients really get better faster. And once this, you can avoid this acute kidney injury, the post-operative stay in ICU is also much less. So that's how it helps in expediting even healing.
Thank you so much, sir. There was another question. Have you observed any difference in ICU stay or post-operative outcomes in patients recovering, receiving alpha keto analog versus the
I think I unknowingly answered this question also that previously, because the ICU stays become much less in patients, and it really helps, especially in elderly patients with multiple issues. Once the ICU stay increases, though you have various other complications. You have more of aspiration pneumonias, you have addiction, ICU infections, and once you get hospital acquired infections, it's really bad for patients. So the shorter the ICU stay for patients with multiple complications, the better are the long-term outcomes. And any drug that helps in reducing ICU stay is a double thumbs up for me, because ICU stay is really, really expensive. Whether small or big ICUs, ICU stay really puts a toll on the financial status of the patients. So that is why I really use this drug a lot for our patients.
Thank you so much, sir. There is one last question, sir. Are there specific clinical indicators or lab values that you monitor generally to decide when to initiate the keto analog therapy?
So, okay, your patient is already having CKD stage 3, stage 4, initiate. Whether there is, I'll tell you why. Whether there is cardiac issue or not, if the patient is CKD, please take it, because it helps in reducing burn. If your patient is already having heart issues along with CKD, you have to use this because you cannot hydrate patients more. When you use this, that time the blood urea nitrogen comes down. Again, it helps the kidneys. Now, if you're having a patient with a liver and a kidney issue, then I use it even more often, because you're already having one risk factor of hepatic encephalopathy where the patient can get disoriented, and I don't want my patient to get uremic encephalopathy. So when the blood urea nitrogen starts rising, I add this drug and it really helps.
Thank you, sir. This brings us to the end of the session. And with this, I would like to conclude with a vote of thanks to you, sir, for taking time and guiding our doctors for a very important alpha keto analog in cardiac patients and how to risk the renal dysfunction. Thank you so much, sir, for joining us and answering all the related questions. Just for the viewers, I would like to share that this session will be available on YouTube. The recorded session will be there. So if you have any comments or would like to share any feedback, please do share it with us. And Dr. Srinivas would also like to answer those queries. Thank you so much, sir,
So
for your time. Thanks a lot.